Hello guys, good evening. I hope all of you are well and good. Welcome to one more an important PYQ based revision session for pharmacology. We'll be starting with an important question, biotransformation. See, as per this question is concerned, biotransformation is like something which is very difficult to predict, or simply as we can tell that it's very difficult to write down. We don't know where to start and where to end. And that's why I'm going to be giving you this particular notes. It's going to be just around like 2 to 3 pages of notes. When you land up in this particular long answer or any short answer based on this topic, you should be able to answer any sort of it. Okay. So before starting this like explanation regarding biotransformation, you have to know the first point. That is, whenever you write a particular long answer, you have to start with the synopsis. And this synopsis, what we are going to be discussing. We'll be discussing about what's the basic principle. Next, what is phase 1 metabolism? What is phase 2 metabolism? What are the determinants affecting the biotransformation? And the determinants includes genetic factors, effect of other drugs, and P-glycoproteins. We'll be talking about all of these things in one by one fashion. We'll be starting with the general or the basic principles wise. See, whenever you administer a particular drug molecule, you have to make sure that drug is going to be excreted out in a normal fashion. How are we planning to excrete it out? A drug primarily is going to get excreted out by the urine. So this drug has to be converted to a molecule which is highly water soluble, so it can be dissolved in urine and thrown out from the body. How we are going to be converting a drug to a water soluble metabolite? Simply, please understand, a drug molecule, if it is ionized, that drug molecule would be a water soluble molecule. So for example, consider we have this drug. Okay, we have this drug molecule as we can see here. This drug molecule has to be converted to a water-soluble metabolite. How do we convert it to a water-soluble metabolite? We have to add a particular moiety. I'm just writing down M over here. M stands for an active moiety, or some molecule has to be added up to the surface of the drug to make it a water-soluble molecule. But unfortunately, this molecule which we have drawn here, or this moiety which we have drawn, cannot bind with any of these parts of this drug, because they don't have a bond to form. Only if there is H plus or O minus, if there is a positive or a negative charge on the surface of this particular drug, this molecule can come and bind with that. Because there is no charges in it, what happens, our body, what it does? It will be adding up a particular charge on it. It will add a particular molecule on its surface. This is a functional group. This is named as a functional group. So what the liver does, or even the body, or even your stomach or the intestines, we have multiple areas where this techniques can happen. So this functional group is going to be added up on the surface of the drug. Now this whole molecule will be designed in such a way that it can form a bond with this active moiety. Now what happens? This active moiety will come and bind with this. It forms a bond with this functional group, thereby converting this whole molecule into a water-soluble metabolite. I hope this is clear. Now this is the drug molecule. Addition of this functional group, this is named as phase 1 metabolism, and addition of this active moiety, this is called as phase 2 metabolism. This is very much clear. Now if you could draw this diagram in your main exams, it would be so much good. And also if you want to complete this diagram, please write down below that functional group addition is nothing but phase 1 metabolism reaction, and this active moiety addition is nothing but phase 2 metabolism reaction. Either you can draw this diagram, or you can come up with this particular like flowchart based phenomena. Either you have to draw that or you have to draw this, but you have to draw any one of this. That will make sure that the examiner knows that you have understood what is metabolism. As we can see in this first sentence, conversion to a water-soluble metabolite. That's what the basic concept of biotransformation. Biotransformation means converting a drug to a different molecule. I hope now you understand what's the meaning of it. The other name is metabolism. All these things are one and the same. So we have this drug molecule. This drug will land up in phase 1 metabolism, which is also called as functionalization reaction, because we add a functional group, following which there will be progression on to phase 2 metabolism reaction. Phase 2 is also called as conjugation reaction, because we conjugate the active moiety over the drug molecule. This is the sequence of what is happening inside the body. So how we are going to be understanding certain things, we have to know what is phase 1, how it is happening, and what are the factors which might govern that. Also, what is phase 2? What are the reactions happening and what are the factors governing that? That's what you are going to be writing down under the question biotransformation. See, when you come across a case scenario or a case-based scenario-based question, you can answer some sort. But when you land up in a single one-liner based a long answer question, when an LAQ sometimes we can have a single one-liner. Define biotransformation, explain about the various steps involved in biotransformation. That's it. That's what your long answer questions, they'll be writing down 10 or 20 nearby. That's the single question. You have to write down the whole concepts as a single explanation. So when you come across those kind of questions, we have to start with this. What is phase 1 metabolism? We'll be explaining about what is phase 2 metabolism, and then we'll be explaining about the factors governing biotransformation. We'll start with phase 1. Within phase 1, you need to write down all these reactions. But this is pretty important. All these reactions are very important. They will expect you to write down these names alone. Oxidation, reduction, hydrolysis, cyclization, decyclization. 5 important reactions. Out of all this, when you write it down, you have to always add up. Oxidation is the most common phase 1 metabolism reaction. This is an MCQ question, buddy. Which is the most common phase 1? Oxidation reaction. Now, this phase 1 reaction can be happening by 2 different metabolisms or 2 different techniques. The first one is called as microsomal metabolism. The second one is non-microsomal metabolism. Microsomal metabolism means it is happening at the SER, smooth endoplasmic reticulum. This is again a question, buddy. Where does microsomal metabolism happen? It will be happening at the smooth endoplasmic reticulum. Whereas non-microsomal metabolism will be happening in the cytoplasm and mitochondria. And this microsomal metabolism can be either induced or inhibited by drugs, whereas non-microsomal metabolism, mostly these are governed by genetic polymorphisms. What's the concept of induced or inhibited by drugs? See, when a patient is under a drug therapy, a single drug therapy, and the patient is been added one more drug, the second drug. This second drug might be inducing the metabolism of the first drug, or the second drug might be inhibiting the metabolism of the first drug. How it is going to be happening? By induction or inhibition of these microsomal enzymes. I hope this point is clear. Now the next one is non-microsomal. There are very minimal drugs which might be either inducing or inhibiting. Instead, there will be genetic polymorphisms. Some patients defaultly will be having hyperactive non-microsomal metabolisms, and some patients will be born with underactive non-microsomal metabolism. That's the difference between microsomal and non-microsomal metabolisms. In your exam papers, we need to write down this as an additional factor for phase 1 metabolism. These points regarding how these reactions are actually happening is like cream on top. Either you can add or you can leave it, no problem at all. What are the enzymes which are responsible for microsomal metabolism? We have CYP monooxygenase and we have flavin monooxygenase. Whereas the enzymes which are involved in like non-microsomal metabolisms, we have epoxide hydratase, esterase, alcohol and aldehyde dehydrogenase, the one responsible for alcohol metabolism, and monoamine oxidase, which is usually named as MAO. And these reactions are actually coming under non-microsomal metabolism. Okay, so you have to write down these points, buddy. First of all, when you come across this question regarding biotransformation, you have to write down that biotransformation is nothing but the structural change which is happening in a particular drug. And how it is going to be happening? By phase 1 and phase 2 metabolism reactions. What is phase 1? Functionalization. What is phase 2? Conjugation. We start with phase 1, write down the list of the enzymes or list of the reactions which are named as phase 1 and classify the whole of this into microsomal and non-microsomal. Write down where it is happening and write down its own classical feature. That would be enough. If you could remember these points, those are additional marks which you're going to be fetching up with. Now let's talk about phase 2 metabolism reaction. Phase 2 metabolism reaction is a synthetic reaction. It needs energy, so we need more amount of ATP, which means the addition of the active moiety needs more amount of ATP. It is faster than phase 1. It is not a slower reaction, it is a faster reaction. Because it is ready to bind, only we need to have the functional group. Now, out of all these phase 2 reactions, we have glucuronidation, we have acetylation, glutathione conjugation, glycine conjugation, sulfation, methylation. All of these 6 reactions will come under phase 2 metabolism reaction. As I've told, this active moiety, if it is a methyl group, it is called as methylation. If it is sulfur group, or if it is glycine, it will be named as glycine conjugation. If that active moiety is glutathione, that will be named as glutathione conjugation. If that active moiety is acetyl group, acetylation. If that active moiety is glucuronide group, then that reaction will be named as glucuronidation. Now, this glucuronide will be starting with glucuronidation, which is the most common subtype. As we know, in phase 1, oxidation is the most common. With the phase 2, glucuronidation is the most common. I'll repeat that. Phase 1, most common reaction is oxidation. Phase 2, most common reaction is glucuronidation. And this is the only phase 2 which can be induced or inhibited by drugs. As I've told, within this phase 2, only glucuronidation can be either induced or inhibited. And it undergoes something called as enterohepatic circulation. So what exactly is enterohepatic circulation? We have some drugs which includes, as we can see, morphine, sulindac, digoxin, OCP, and piroxicam. Morphine is an opioid. Opioid is the one which is used for painkillers. Like morphine is used for chest pain, myocardial infarction. For relief of pain, we use morphine. Sulindac is an NSAID, non-steroidal anti-inflammatory drug used for pain. Digoxin is a drug which is used for heart failure. OCP is nothing but oral contraceptive pills. And piroxicam is again a non-steroidal anti-inflammatory drug. Okay. Now, out of all these drugs which we have, all these drugs will be having a classical feature, and that is, these drugs, whenever it is taken up by per oral route, it gains entry into the liver, guys. Now, what the liver does, that will land up in phase 1 and phase 2. And here, what exactly is happening? The drug molecule is bonded with glucuronide molecule. Now, this combination behaves as an inactive component. It is going to be excreted out from the body. But this molecule is bigger in size, because especially these drugs are bigger in size. So it cannot get filtered from the glomerulus. So the body has decided it to be excreted out by the bile and liver. This will be excreted out from the liver. It will be coming out through the bile. It will gain entry into the intestines. Now from the intestines, it gains entry into the large intestines. What is something special in the large intestines? We have something called as commensal bacteria. It is called as commensal bacteria, or a normal bacteria situated inside your intestines. These commensal bacteria which are present has got a classical feature, that is breaking down the drug and the glucuronide. It is called as deglucuronidation. It's called as deglucuronidation. So what exactly this drug molecule, it will be separated out from the glucuronide molecule. This step is named as deglucuronidation. I hope this is clear, my dears. Deglucuronidation. Because of this deglucuronidation, what has happened here? The drug molecule is separated out from the glucuronide and the drug molecule is getting reactivated. Now this reactivated drug which are there in the large intestine will be gaining entry back into the blood vessel, because it is not an inactive component. It will gain entry back into the blood, and we can see the drug's response one more time. Simply it is called as recycling the drug. The drug is designed to be expired, drug is bonded with the glucuronide, decided to be thrown out from the body. When it gains entry into the large intestine, again it is recycled, gaining entry back into the blood. Now this action will be there one more time, and from the blood again it will gain entry into the liver. Again there will be a drug bonded with the glucuronide. It will come into the large intestine, deglucuronidation, again the drug will gain entry back into the blood, again the liver. This whole process will be happening on a sequential basis. So does it mean that drug will never be excreted out? No. For example, here 100 molecules are coming up. Here what happens, around 80 molecules of the drug will be deglucuronide, 20 molecules will not be deglucuronidated. So this 80 molecule alone is going to be reabsorbed. Now out of this 80 which is coming into the liver, here when it comes, only 60 is going to be reabsorbed, 20 is going to be let out. I hope you understand. That is a ratio between which is going to be glucuronide and which is going to be deglucuronide. This concept of how the drug molecule is being constantly shifting from the intestines back into the liver, intestines back into the liver. This is what called as enterohepatic circulation. I hope this is clear, buddy. So this is named as enterohepatic circulation. Two questions are there. First of all, so what is the clinical implication of knowing about enterohepatic circulation? Any drug, if it is following enterohepatic circulation, will be having a long T-half. Why is it having a long T-half? Because this drug is not getting excreted out. Drug is accumulated more, thereby the drug's action will be long. The next thing, sir, how do we remember like which drug will be producing that? We have listed 5 drugs here. Just remember with this mnemonic. Remember with this mnemonic. MS Dhoni is overpriced. Is overpriced. This is just a mnemonic. Those guys who are fans of MS Dhoni, like how I am also, this is just a mnemonic, don't take it seriously. Okay, so MS Dhoni is overpriced. That's the mnemonic. MSD is overpriced. M is for morphine, S is for Sulindac, D is for digoxin, overpriced, O is for OCP, and P is for piroxicam. Good. Now moving on to the next part, next phase 2 reaction named as acetylation. One famous question will be there within acetylation. What are all the drugs which are included in acetylation, and what is the clinical implication of knowing about which drug is following in this acetylation? First of all, we'll see what are the drugs which are involved in acetylation reaction. We have a mnemonic here which goes SHIP. SHIP. This is a very famous mnemonic. But of course, we have to extend it a little bit. SHIP runs in which power? AC power or DC power? Alternating current and direct current. It follows by direct current. SHIP DC will be the mnemonic. S is for sulfonamides, hydralazine, isoniazid, procainamide, dapsone, and clonazepam. Okay, what is this sulfonamide? Sulfonamide is an antibiotic agent like sulfasalazine or sulfa drugs. Hydralazine is an potassium channel opener. Actually, it is simply a vasodilator agent. Hydralazine is a vasodilator agent. Isoniazid is an anti-tubercular drug. Procainamide, anti-arrhythmic agent, not anti-tubercular drug. That drug is pyrazinamide. This is procainamide. Dapsone, again anti-leprotic agent used for leprosy. Clonazepam, again drug name is ending with zepam, which is a benzodiazepine drug. Done. Now the next one is, what is the clinical feature or clinical implication of knowing about acetylation? There are a lot of genetic polymorphisms. These genetic polymorphisms can be classified into 2 major subtypes. Those or certain patients will be named as slow acetylators. Slow acetylators, and certain patients will be named as fast acetylators. Slow acetylators and fast acetylators. What's the clinical implication? Name itself is there. Certain patients, this activity would be slower. For certain patients, this activity would be quicker. So how do we put forth slow acetylators? If a patient is a slow acetylator, you didn't know that, you administer one of these drugs. What will happen? This drug will not get metabolized, which means these drugs will get accumulated in the body to produce toxicity symptoms. This will lead on to toxicity symptoms. On the other hand, fast acetylators, if all of these drugs are quickly getting metabolized, none of the drug will be accumulated in the body, which means the efficacy of the drug is going to be decreased. I hope you can understand about these terminologies. Drug is accumulated, toxicity. Drug is not getting accumulated, efficacy or the effect of the drug is going to be decreased. Is that good? That's it about acetylation. As per your phase 2 metabolism reaction, you need to concentrate primarily on the first 2 reactions, glucuronidation and acetylation. What about the others, sir? Just remember the drug names. That would be enough. Glutathione conjugation is how paracetamol is getting metabolized. Again, glycine conjugation, salicylic acid. Sulfation, we have methyl dopa and acetaminophen. Acetaminophen is nothing but paracetamol. Paracetamol is metabolized by glucuronidation, glutathione conjugation and also your sulfation. We have methylation, which is done by dopamine and epinephrine. These are physiological neurotransmitters involved in adrenergic nervous system. Okay. You just remember these 5 things, buddy. Just a small recap of what we have discussed. We discussed about what is biotransformation, and we discussed what to draw. Either you can draw a diagram or you can draw a flow chart. Then we came with phase 1, 5 important phase 1 reactions, classified into 2, microsomal, non-microsomal. Again, we discussed with phase 2 reactions. Within phase 2, we discussed about 5 important reactions: glucuronidation, acetylation, glutathione, glycine, methylation, and sulfation. Moving on to the last part within this long answer, you have to write down the determinants affecting biotransformation rate. Please expect this to be asked as a separate subheading based question. It might be asked, because usually we'll skip this. Usually students will skip to write this because they feel it is very much difficult. But make sure that this is going to be easier for you, because I will try to make it as easier as possible. Within this determinants, which might be affecting the biotransformation, 3 topics we have to write. What are the 3 topics? Genetic factors, effect of other drugs, and P-glycoproteins. Only 3 topics we have to write. We'll first start with the first one, genetic factors, which means pharmacogenomics, which we have discussed already, like slow acetylatase, fast acetylatase. Some patients will be having slow activity, some patients will be having fast activity. The second one is effect of other drugs. As I've told, you have administered the first drug. The second drug, if it is inducing the microsomal enzymes, that will increase the metabolism. If it is inhibiting the microsomal enzymes, that will be decreasing the metabolism. As I've told, CYP monooxygenase enzymes will go back. We'll go back to that. I hope you remember that CYP monooxygenase, just for additional information purposes. CYP monooxygenase, these enzymes are together named as CYP 450 enzymes. Okay. So first of all, what is this 450? 450 means these enzymes will absorb light of wavelength 450 nanometers or 4500 Armstrongs, whatever you want to name. That's why it is named as CYP 450 enzymes. The most common enzyme is CYP 3A4. This is the most common enzyme, followed by CYP 2D6, followed by CYP 2C19. These are the 3 most common enzymes with which more than 50% of the drugs will get metabolized. Okay, you just need to remember at least this, buddy. At least this about CYP 3A4, which is the most common subtype of enzymes out of all the other enzymes. Good. Now we have some drugs which might be either inducing or inhibiting the CYP 450 enzymes. We have a bigger list. Sir, do we need to remember all of these things? It's not actually, at least 3 or 4 we expect you. But more you read, that is going to be easier, because we're going to be explaining that with a mnemonic. We had a mnemonic called as GPRS cell phone, but that is not enough to write down for your main exams, because as I've told, when a paper is getting corrected, consider again, I'm an examiner. I'm looking at the answer papers from the morning till evening, and by around in all the because same question for all the students, and I'm just repeatedly seeing that GPRS cell phone. One guy who writes more drugs, well, that's the reason why we are sitting here. That's the reason why we are here, to look into these classes. Because if you want to be there in that herd, there is no need for you to sit down and look into these classes. If you are sitting down to look into these classes, it means you are going to be shining up in a different way. Look into that. We have a mnemonic there: microsomal enzyme inducers and microsomal enzyme inhibitors. What are those? Priyanka Chopra grabs 2 cigarettes. Queen Priyanka Chopra mixes vodka with ice. This is just a mnemonic again. Okay, I have no role with MS Dhoni or Priyanka Chopra. Okay. Priyanka Chopra grabs 2 cigarettes. Priyanka Chopra, phenytoin and carbamazepine. Both these drugs are anti-epileptic drugs. Grabs, Grabs. G is for griseofulvin, the antifungal drug. Rifampicin, anti-tubercular drug. Alcoholic, which is chronic alcoholics. B is for barbiturates, which is your like sedative hypnotics. St. John's wort is an antidepressant drug, a plant derivative, which is a powerful microsomal enzyme inducer. 2 cigarettes is the mnemonic. T is for troglitazone. If a drug name contains GLI, it is a drug which is targeting diabetes mellitus. It is an anti-diabetic drug. O is for omeprazole, which is a proton pump inhibitor, which is used for gastric ulcer. Cigarette is for cigarette smoking. Okay. What about this microsomal enzyme inhibitors? We have Queen Priyanka Chopra mixes vodka with ice. Queen is for quinine, quinidine, quinolone, and fluoroquinolones. Quinine is an anti-malarial drug. Quinidine is an anti-arrhythmic agent. Quinolone and fluoroquinolones are antibiotic agents. Queen Priyanka Chopra. P is for protease inhibitors, which are anti-HIV drugs. The drugs name which are ending with navir. Yeah, ritonavir, indinavir, saquinavir, nelfinavir, unavir, inavir, all the navir. All these drugs are named as protease inhibitors. C is for cimetidine. Cimetidine is an H2 receptor antagonist, again like ranitidine, used for gastric ulcer. Chloramphenicol is an antibiotic. Cobicistat is a selective CYP3A inhibitor. There is no need to know what exactly is the drug. Just for understanding, I'm writing it down. Priyanka Chopra mixes is for macrolides and methadone. Macrolide is an antibiotic, methadone is an opioid. Vodka, of course, this is not the spelling of vodka, we all know that, because just for the mnemonic purposes again. V is for valproate and stiripentol, both these drugs are antiepileptics. O is for oxetin, which is fluoxetine. What is fluoxetine? SSRI, selective serotonin reuptake inhibitor, used for depression. Omeprazole, again a proton pump inhibitor. Omeprazole is a drug which has got dual activity. It tends to inhibit and induces. It inhibits CYP2C and it induces CYP1A, as we can see here. D is for diethyl carbamazine, which is anti-filarial drug used for filariasis. G is for grapefruit juice, normal grapefruit. Grape juice is different, grapefruit juice is different. A is for azole drugs. Azole drugs are antifungal drugs. Acute alcoholics, amiodarone, which is an antiarrhythmic, and I is for isoniazid, which is an anti-tubercular drug. So do we need to remember all of these drugs? It's always better to remember all of these drugs, right? But at least please give us some so that we can write down for the exams. They will be seeing whether you have written these drugs. You should have to write phenytoin. There should be rifampicin, chronic alcoholics, and cigarette smoking. At least you have to write down these four. At least you have to write down these four. More you write, more is going to be better. And how do we remember that? Just imagine I'm a chronic alcoholic, right? I'm a chronic alcoholic. I'm having an alcohol in my hand and I have a cigarette in my hand, right? I'm just smoking and I'm drinking alcohol. I'm smoking and I'm drinking alcohol. I'm a chronic alcoholic and sitting like that in my room. And I am the complete image of a microsomal enzyme inducer. If you could remember that, it's easier for you. Powerful microsomal enzyme inducer, which is a chronic alcoholic and a cigarette smoker. Whereas inhibitor, what are the things which you have to write down? You have to write down all the queen drugs, very important. Protease inhibitors are important. Macrolides are important. Grapefruit juice is important. Azoles are important. At least you have to write down these molecules as per your microsomal enzyme inhibitors are concerned. Good. With this, we'll look into the clinical implication. This is no need to write down, but when you come across a short answer where they ask about microsomal enzyme inducers and inhibitors, you might expect this particular as a sub-heading based question. So we have to write it down. What's the clinical implication of knowing the microsomal enzyme inducers and inhibitors? First of all, you administer drug molecule A, which is actually metabolized by CYP enzymes, and you add drug molecule B. Now what happens? What if drug molecule B is a microsomal enzyme inhibitor, and what if drug molecule B is a microsomal enzyme inducer? With that, we're going to be explaining the clinical implications of it. You just write down this flowchart. Even if this question is not been asked, or even if they have not asked separately about the clinical implications, you write it down, because this flowchart makes a lot of sense. It will create a feel with the examiner. If the drug molecule B is a microsomal enzyme inhibitor, it will produce accumulation of drug molecule A, because that's how the concept is. Because it is inhibiting the CYP enzymes, thereby the drug molecule A tend to accumulate, which itself produces toxicity of drug molecule A. Whereas vice versa, if the drug molecule B is an inducer, that will decrease the effect of drug molecule A. So if drug molecules A effect is not seen in the patient, what you do, you increase the dose of drug molecule A to see the desired response, because normal dose is not working. So what we do, we increase the drug dose. And because of continuously administering more amount of drug, tolerance will be developed. Just a small way to understand, microsomal enzyme inhibitor will induce toxicity, whereas microsomal enzyme inducers will induce tolerance. Clear? Moving on to the last part. P-glycoproteins. What is this P-glycoprotein, which are also called as MDR1? See, consider here is where your intestines are. Okay, if you draw this diagram, because P-glycoproteins are a separate question asked in a lot of the exams. Consider here is where the intestines are, and we have the blood vessels. Here we have blood vessels, and in between we have a separate transporter. This transporter is what named as P-glycoproteins. Okay. What is its function? Consider a patient has taken a drug, and that drug is digoxin. Okay. Consider a patient has taken a drug, and that drug is digoxin. This digoxin is a drug used for heart failure. This digoxin has been taken up by per oral route. It gains entry into the intestines. What's the next step, guys? Drug tend to get absorbed. What is the concept of absorption? From the site of administration, how the drug is gaining entry into the blood, study of that is called as absorption. So this drug molecule gains entry into the blood. So simply the digoxin is getting absorbed. But here is where the action of this P-glycoprotein will start to function. This is an efflux pump. Simply put, this is an efflux pump. So because of this, what happens? This drug molecule, or digoxin, which has gained entry into the blood, will be thrown back into the intestines. Digoxin, which has gained entry into the blood, will be thrown back into the intestines. This is an efflux pump. So what happens? Patient will be taking digoxin, but the digoxin response will not be seen for the patient. Why? Because none of the digoxin is being taken care of. It is gaining entry into the blood. All of the digoxin is thrown back into the intestines, and the digoxin is excreted out via the intestinal motility. That's the reason why these molecules will tend to be named as efflux pumps. We have one more example to be explaining that. And that is, consider here is where your blood vessels are. Consider we have the blood vessels here. You can draw this diagram. P-glycoproteins, if you come across the question, please draw these 3 diagrams. Very important one. Now here we have the blood-brain barrier. Here we have the blood-brain barrier. Blood-brain barrier is there. Okay. Now consider the patient is being administered a drug which is loperamide. What is loperamide? It is an opioid. Okay. Loperamide is an opioid drug which is used for diarrhea, right? We had a brand name called as L-Doper, very commonly used. It's a capsule. It's also there in the tablet form. But because it is an opioid, it has got more abusive potentials. Now what happens? When the patient is taking up loperamide, it gains entry into the blood vessel, guys. Now from the blood vessel, this loperamide tend to cross the blood-brain barrier, gain entry into the brain. If it is gaining entry into the brain, it has got increased abuse potentials, because this drug is moving into the brain, and the patient will be having abuse potentials, because patient will be having the high, or a patient will be having that addictive potentials of this loperamide. Now here comes this P-glycoprotein. We have a P-glycoprotein present there. This P-glycoprotein, which is present over the junction between the blood vessel or on the blood-brain barrier, this is responsible for taking this loperamide from the brain and throwing it back into the blood vessel, which means P-glycoproteins prevents loperamide abuse. Is that understood, buddy? Prevents loperamide abuse. Okay, this point is done, which means P-glycoprotein is doing a good job there. But at the same time, I'm going to be explaining about one more concept regarding the same area, buddy. Consider here is where the blood vessel is, okay? And here we have cancerous cell. Okay, this is a tumor cell. This is a tumor cell. Inside the tumor cell, we have an enzyme called as dihydrofolate reductase enzyme, DHFR, dihydrofolate reductase enzyme. Now, this tumor has to be treated with an anti-cancer drug. Now, for the treatment of this cancer, you administer a drug, and that drug is methotrexate. We administer a drug named as methotrexate. Good. This methotrexate, what it does, it gains entry because methotrexate is been administered by per oral route. It will mix up into the blood. From the blood, this methotrexate will gain entry into the tumor cell, thereby tend to inhibit the dihydrofolate reductase enzyme. That is the mechanism of action of methotrexate. Here also, we have a specific P-glycoprotein. This P-glycoprotein is not a nature derived. It has been developed by the tumor cell itself, because the tumor cell identifies that, oh my god, this idiotic guy is coming from somewhere and he is inhibiting this DHFR, thereby he is killing off our own community cells. So what the tumor cells, it will design a P-glycoprotein, and with the help of this P-glycoprotein, this tumor cell will throw the methotrexate back into the blood vessel. Again, here it is functioning as a efflux pump. Very much understood, buddy. Here again, P-glycoprotein is acting up as an efflux pump. Okay. Now, with this knowledge in mind, this is a mechanism of how resistance is getting, I hope you can understand that. This is how resistance is getting developed. That is the reason why P-glycoproteins are also named as MDR1, multi-drug resistance transporter type 1. This is the full form is multi-drug resistance transporter type 1. That's called as MDR1. Now, we have lots of implications here. This first one is we have this P-glycoprotein inducers, P-glycoprotein inhibitors. Within inducers, we have a mnemonic PR drugs. Inhibitors, we have vaccine Q drugs. PR drugs is easier, buddy. The same two drugs which we have discussed in microsomal enzyme inducers, phenytoin and rifampicin, we have written it here. P-glycoprotein inhibitors, this is pretty important. Even in your main exams, if they ask about P-glycoprotein, or they can ask multi-drug resistance transporters also, don't land up in panic attacks. You just need to write down this is a determinant which affects the biotransformation of a drug. Next step, you write down this P-glycoproteins, also named as multi-drug resistance transporter type 1. And you draw all these diagrams and you write down your P-glycoprotein inducers and inhibitors. Within that inhibitors, we have this mnemonic vaccine Q. This is pretty important. V is for verapamil, amiodarone, cyclosporin, itraconazole, nifedipine, erythromycin, quinidine. Vaccine Q is the mnemonic. What is verapamil? It is a calcium channel blocker. What is amiodarone? Anti-arrhythmic agent. Cyclosporin, again an immunosuppressant drug. Itraconazole, azole, which is an antifungal drug. Nifedipine, calcium channel blocker. Erythromycin, clarithromycin. So drug name is ending with mycin, but the drug name also contains romycin in it, which means it is a macrolide. Just close your eyes and hear that. Macrolides are romycin agents. Macrolides are romycin agents. Erythromycin, clarithromycin, roxithromycin, telithromycin, all these are romycin agents. Quinidine is an anti-arrhythmic agent. Okay, now if you have this knowledge in mind, now try to guess. Here, as we can see, digoxin is there. Digoxin is absorbed, but it is rapidly moving back into the intestines by a P-glycoprotein. This specific P-glycoprotein is getting inhibited by a macrolide, which is clarithromycin. This is specifically getting inhibited by a macrolide, which is clarithromycin. Is that clear, buddy? So clarithromycin, what it does? Now you have to guess, my dears. If you administer clarithromycin along with digoxin, what happens? Clarithromycin inhibits the P-glycoprotein because vaccine Q is the mnemonic. More digoxin will be gaining entry, but none of the digoxin will be going back into the intestines. This clarithromycin, you know what's the clinical implication? This will increase digoxin levels. Thereby, this will produce digoxin toxicity. This will produce digoxin toxicity. First step is done. We'll move to the second part where we explained about loperamide. Yeah, just a small recap. Loperamide, the opioid, gains entry into the brain by this, usually it is crossing up, but it is thrown back into the blood vessel by this P-glycoprotein. We have one specific P-glycoprotein inhibitor which is having a major implication here, and that is P-glycoprotein inhibited by quinidine. Quinidine, we know that vaccine Q mnemonic Q is the drug which is quinidine. So what happens when you administer quinidine along with loperamide? Yeah, quinidine, this quinidine, what it does, inhibits the P-glycoprotein, which means more loperamide will gain entry into the brain. Thereby, this quinidine will increase loperamide abuse. Patients who are taking loperamide along with quinidine, there is increased risk of loperamide abuse by the patient. Now the last batch, we had this methotrexate, which is an anti-cancer drug. It is gaining entry into the cell, thrown back by the P-glycoproteins. But what if you administer a specific P-glycoprotein inhibitor? A specific P-glycoprotein inhibitor here, which is the calcium channel blocker named as verapamil. Okay, now comes the question, guys. What if you administer verapamil along with methotrexate? What if you administer verapamil along with methotrexate? This verapamil will block the P-glycoproteins. Methotrexate will be moving, but it cannot be moved back into the blood. More methotrexate accumulation in the tumor cells, more anti-tumor potentials of methotrexate. So verapamil can be used to potentiate, methotrexate's potentiates methotrexate anti-cancer activity. I hope you can understand that. Potentiates methotrexate anti-cancer activity, because more methotrexate activity will be there. Okay. With this, we complete our biotransformation, guys. See, guys, within biotransformation, even if you face a long answer, there will be a separate subheading where you will be forced to write down microsomal enzyme induces inhibitors or P-glycoprotein induces inhibitors, because most of the students will skip that. So when you come across this P-glycoprotein, when you can explain it with 3 beautiful diagrams regarding the function of this P-glycoprotein, that is known to stop the giving marks for you, because that's how the key is also going to get developed out. Just a small recap of what we have discussed for this topic, buddy. We were talking about biotransformation. We explained about what's the basic principle. We explained with a diagram or with a flow chart. Phase 1 metabolism, please write down the 5 different metabolisms and microsomal and non-microsomal. Phase 2 metabolism, we explained about 6 different phase 2 metabolisms. There we explained a little bit about how MS Dhoni is overpriced, and what are glucuronidation. We explained about SHIP-DC, which is acetylation. Determinants affecting biotransformation, genetic factors like pharmacogenomics, like fast and slow acetylators. Effect of other drugs, where we explained about microsomal enzyme inducers and inhibitors and its clinical implications. Priyanka Chopra grabs 2 cigarettes, Queen Priyanka Chopra mixes vodka with ice. P-glycoprotein inducers are PR drugs, inhibitors are vaccine Q drugs. Verapamil, amiodarone, C is for cyclosporin, itraconazole, nifedipine, erythromycin, clarithromycin, and Q is for quinidine. There we explained about the beautiful interaction, 3 different diagrams to explain about how digoxin's absorption is going to be increased by clarithromycin. Then loperomide's abuse potential increased by quinidine, and methotrexate's anti-cancer potential increased by verapamil. We have discussed about all these 3. When you write down all these points, that is going to be more than enough to secure as much marks as possible. All the best, guys. We'll meet up in one more question, and all the best.